persons, people who inject drugs, sex workers, and their clients. And I'm sure you may be asking, why are we talking about key populations? Why is it special and unique to add a discussion on key populations to this particular conference? And I'll take you back briefly. During the adoption of the 2020 Agenda for Sustainable Development, member states, including countries in this region, pledged to ensure that no one is left behind. And the reason for taking on that tagline, no one is left behind, is because of some of the lessons we learned when we evaluated our results as a result of our work during the MDGs. We realized we can achieve targets, but there are certain populations we consistently leave behind, even in terms of social protection coverage. So today we want to give those populations a voice to talk about their experiences, for us to assess the extent to which our programs actually cover our respective populations. In some countries, these barriers are due to the legal framework, which is a bit punitive and doesn't give the people a voice. In other countries, even when the legal framework is okay, the societal norms and practices don't make it possible for such people to come out. In others, stigma and discrimination becomes a major barrier. So these are some of the reasons why populations are left behind. And we have assembled a very diverse team. I'll be introducing them very shortly. And we have a voice of a social protection expert, a voice of someone representing people living with HIV, a voice of someone representing sex workers, a voice of representation from men who sleep with men or gay men, and then voice from an expert in community mobilization and organization. And we will bring you 3 countries which are at different levels or stages in terms of their ability to cover the populations we are talking about. So without much ado, let me go straight to the introduction of the panelists. And I'll start with David Chipanta. So David, an economist by profession, started his UNAIDS career as the UNAIDS country director in Liberia. He's currently the UNAIDS Social Protection Senior Advisor in Geneva, and he has considerable knowledge and experience in HIV-sensitive social protection. David, we invite you to take your seat. The next person I'll introduce to join us here is Baby Rivona. Baby is the co-founder of the Indonesian Positive Women Network. She is also the PITCH country focal point. Baby is a board member of the Indonesian AIDS Coalition and on the steering group of the Women Won't Wait campaign. Baby, please take your seat. The third person I'll introduce is Shama Kakal. Now, Shama is a management and community organization expert. She is currently the CEO of SWASTI, the global public health organization designing, delivering, and supporting solutions for the health and well-being of the poor, headquartered in India. So I see Shama is here before I called her. Thank you very much. And the last panelist I'll be introducing is Harry. Harry is the project officer of Positive MSM Working Group in the Asia Pacific Network for people living with HIV. It's based in Bangkok, Thailand. Harry worked as the national program manager for GWL-INA, a gay men, transgender, and other MSN network in Indonesia between 2008 and 2014. So thank you very much, Harry, for giving us the Thailand experience. Now I'll call my colleague from the World Food Program, the UNAIDS focal point, Michael Smith, to also join us. And Michael's duty is simple. He will be wrapping up and giving us the key messages that came across in this session. So without much ado, I think I'll call the first speaker. We'll go in the order of the program. So David would come first, followed by Shama, Baby, and then Harry. So David, over to you.
Thank you very much, Kofi. It is really my great pleasure to make this presentation on behalf of Emon Murphy, who's the UNAIDS Director for Asia Pacific. This, in short, is the situation of HIV. As you can see on the left side, the number of people living with HIV has been increasing. We have roughly about 36.9 million people living with HIV globally, and the increase is largely due to the availability of antiretroviral therapy. On the far right, you can see that in general, since 2010, the number of new HIV infections have been going down, but we are off track in meeting our prevention targets of ensuring that we have less than 500,000 people getting infected every year by 2020. The situation of HIV in Asia Pacific, on your left side there you can see a modest decrease in you can see a modest decrease in new HIV infections of around 9%, and you can also see a decrease in AIDS-related deaths of about 24% since 2010. Even if this decrease is happening in Asia Pacific, we have some worrying trends. A few countries, you can see that the HIV infections is increasing, including where we are here in the Philippines, Indonesia, Pakistan. There you can see that the trend is upward. So this is what we have at the moment. In terms of people that are really newly infected with HIV, roughly what we have is that key populations like Kofi was talking about are the hardest hit with HIV. In Asia Pacific, gay men and other men who have sex with men, they account for roughly about 30% of new HIV infections. Sex workers, interestingly enough, a small proportion, about 5%, but the clients and partners of sex workers, they give us again a huge proportion of new infections. Then we have people that inject drugs with the increase in heroin and the reduction in harm and the reduction in harm reduction services is giving us an increase, also a good proportion of increase in new HIV infections. The good thing is that there are a lot of interventions around which if we combine with social protection, this can help us go to zero new HIV infections. As UNAIDS, we have the UNAIDS strategy, and we have the political declaration for ending AIDS, and within this strategy we have 10 targets. Target number 6 relates to strengthening national, social and child protection systems to ensure that by next year, by 2020, we have 75% of people that are living with HIV, those that are affected, and those that are at risk are benefiting in one way or another from social protection services. So this target arises from a lot of evidence that has been generated by some of the organizations here and even outside that show direct linkages between access and use of social protection with HIV in terms of impact mitigation, prevention, and even access and retention in HIV treatment. And some of the evidence also has come from this region. In Cambodia, India, Indonesia, we have again good evidence that shows that when we combine, when people that are at risk or are affected or living with HIV access social protection benefits, that can help them to protect themselves from HIV, or it can help them to stay on HIV treatment. So you can read more about this evidence in some of these publications that we are showing. This is now looking at the sensitivity of looking at the strategies in Asia Pacific that are approved and also whether countries have those strategies, whether they are approved or not, the social protection strategies. And the good thing is that most of the countries, at least half of the countries that responded to our surveys, they do have a social protection strategy. So that is already a good beginning for us. If we go to the next slide, you see we asked the countries, okay, you have a strategy that is approved. Can you tell us if this strategy refers to HIV in one way or the other? So what you can see there is the number of countries that have their strategies referring to HIV. There were around 21 countries from the region that responded, and out of those 21 countries, 16 of them, their strategies refers directly to HIV. There are other sections that we ask the countries, and we see, this is like the largest, we see those sections going down. For example, does your strategy cater for key populations? Does your strategy cater for young people? Does it cater for children? We find those areas going down. In terms of the barriers that people that are living with HIV or at risk or affected from HIV face, as Kofi said, some of them include stigma and discrimination. Some of our populations will not go to the services because they are afraid that we are not going to treat them properly. Some populations will not go again because the process is very complicated. If we ask people to fill in so many forms to go and get different certifications from the doctors, people are not going to go. But even some basic barrier includes just the awareness of whether these programs exist, and if it exists, am I eligible to access the program? And we find that many of our populations, they don't have good information about these programs. Then we looked at whether the coordination mechanisms also incorporates people that are working on HIV, and we find that there's a good inclusion of those of us working on HIV into coordination mechanism. That is important for us because it can help us to make sure that when we are targeting our populations, we are also able to provide inputs on how best we can reach the populations that we want to target. In terms of moving forward, there are about 4 things that we feel are very critical. The first one is really building bridges with communities, with governments, with donors. If we can all sit down together and to strategize, that can help us move forward. This is what has helped us move quite forward with HIV. The second one is those barriers that we spoke about. We can find ways of breaking them down. Most of them, they do not require a lot of money. And you will hear more good examples from my colleagues on how some of those barriers have been broken down. And in terms of reaching our populations, we recommend that we try and meet the multiple needs of people. Just the social cash transfer on its own is not good enough. We have to connect them to other services, to incentives. We have to connect them also to socio-economic approaches so that in combination that can help these populations. The last one is that we have to find ways of accelerating the implementation of social protection programs, of HIV aspects of social protection programs in governments. This map shows where we have been to really try and activate the core programming and co-implementation of HIV and social protection. The yellow, those are the countries that are planning. The light green, those are the countries that have implemented. And the small dots, those are places where we have gone to really sell this idea. And we have been to Latin America, to Africa, and now we are here in Asia Pacific, and already we do have countries picking this up. Cambodia, for example, is going to be one of the good front runners. Bangladesh, here we have our UNAIDS country director. So together we try to see how we can also make social protection work for people that are affected by HIV. Thank you very much.
And can I ask for my presentation to come up? No, this is babies. So mine's got a big one which says challenging or challenges and opportunities for HIV protection. Good morning, everybody, and thank you, David, for setting that up so nicely for me. I am going to be largely speaking about my experience from the work that we have done in India. And I've had the opportunity to work at both the national, the state, and directly with community organizations on demand generation, access, facilitation of social protection, and that's the experience that I will be talking about. I think very quickly, I'm going to skip through the slides because my timer is already on and the slides haven't come back up. But one thing that when David was speaking, that's something that I think I really must say is that social protection is not just critical for those living with HIV. It's a huge requirement for preventing the increase in AIDS incidence. And this is the work that we've seen in India and that I will talk about a little bit more. My slides are up here, so. All right, so I think the first, this is sort of the summary and I will go into a little bit more detail, but it is possible to rapidly expand social protection uptake in the communities for the key populations with strong government leadership. We have seen pilot initiatives in India as early as 2011 where we spent time trying to understand what the barriers were, and I think David has already put those barriers out specifically, but we wanted to understand how we could overcome those barriers. And based on that, we have, at the national level, scaled up certain mechanisms, and very specifically the experience of the Avahant Phase 3 program, which in India was called a social protection program, but had social protection, financial inclusion, access to legal services, along with other preventive health services. And we saw that it's possible to ensure that benefits were actually received in the hands of communities. This is not just design of schemes and interventions, but this is about $41.7 million delivered as benefits in the hands of the communities. And we have seen that access to schemes have been able to move up from 37% at baseline in about 2 years to about 81%. Social protection does lead to better quality of life. Again, small study that we did with people living with HIV who were enabled to access a variety of different social protection schemes from the government. And we did an impact assessment over time. So 4 years later, we found that 77% of PLHIV were reporting better CD4 counts. And the PPI reporting also showed improvement, which was significant. And with people living with HIV, we are finding that monthly payouts do make a difference versus something that they get every 6 months or once a year. And community support is a huge piece. So it's not just about the financial incentives or the schemes and the programs, but how they're delivered and the community interaction and support that is just as key. And finally, Tina George was talking this morning at another session on integrated information management, and we were all talking, that session was talking about the delivery chain of actually how services or schemes get to the community. And I was heartened to see that outreach was number one. And often outreach is a piece that gets left out, but outreach is key for closure of this whole process, because we often talk about, is somebody eligible, how do they apply, how do they receive it, but we often forget that there are people who don't receive it, so there's a denial of service. And if something is denied, then they need to know why, and that loop has to close back. And the information gaps also often are from the fact that there is nobody providing outreach or information about these various schemes. All right, very quickly, this is over India's information. I think most of you are familiar, so I'm not going to go into it. Again, we're currently at about 79% people know their status. We don't yet have data on how many are virally suppressed. Again, something that David already talked about, I'm not going to spend a lot of time, but this is really the context that a lot of people don't have the information. There is an inefficient delivery mechanism, and there is low uptake, therefore. In India, the components of social protection, there are various many ways to group these baskets, but we've largely looked at them as civic identity. The documentation that enables you to access services is often the first barrier. After that, you have access to a whole basket of entitlements and services and schemes. This varies, of course, across countries, and this is what we have in India. Financial inclusion is a key piece we found, and there are many schemes that do provide access to livelihoods, and this is something we do facilitate for key populations and people living with HIV, and of course we have other schemes, including legal aid. All right. As I've already mentioned, we did pilots to understand, and one of the things that's really worked for us is a single window mechanism that we identified, because people were running to multiple departments, multiple offices to try and get access to different schemes, and this is a big barrier. So a single point where you come in, actually provide all your information, and this single point today is often the community organization. So if there are sex worker organizations or a trans person's organization or a PLHIV network, they are the organizations that function as a single window. They collect all the applications. The applications are then scrutinized through or with government agencies and then fast-tracked for provision of the benefit. And this we've seen has really enabled uptake to increase. Of course, we needed to make information available, so simultaneously what we've done is created a database of all HIV social protection schemes. So of course the database is of all schemes, but then which ones are the ones that are most relevant for the key populations that we're working with. We've done this at the national as well as at the state level. So again, the challenges, David mentioned some of these. One thing we have to realize is it's not just about stigma prior to accessing schemes. There's also some schemes that require disclosure of identities. In the context of India, for example, having to disclose that you are a sex worker to access a scheme can often mean that women will not come up because you have to tell a government agency that you are a sex worker. So these are some of the issues, not just in how you deliver the scheme, but in how you design and communicate and provide information to about the schemes. This is something that is still an issue. We've have a lot of schemes, but we would see better uptake of some schemes if we could address the design of some of these schemes. DAPCU is a district AIDS prevention control unit which existed within the government mechanism, and they were the key enablers for the single window mechanism that I described earlier. As the HIV program has become more and more mainstreamed, this unit has actually gotten absorbed with the district level health system. And what we're finding is that the new people within the district don't necessarily have the perspectives about the key populations or the HIV program, and therefore the response is not necessarily the same as it used to be a few years ago. So I think over the phases of how a social protection system rolls out in a country and becomes more and more mainstreamed, how do we keep the empathy, how do we keep the focus on the key populations and people living with HIV becomes very, very important. I think the larger piece of monitoring and manage, this was again something that came out with the integrated information management system session earlier this morning, was that it's not just one time, it's ongoing because needs change over time. How do you manage, how do you monitor, how do you report this for the same people or for a new set of people? So we've seen that still continues to be a challenge because we don't have enough ground-up data. So this is my last slide, and what I think the opportunities are enormous, not just in India, but across the region. We find that social protection is a huge pull mechanism for key populations. Traditional programming of bringing people for testing or giving out condoms is actually pretty passé now because we've done it for 20 years. But enabling access to a variety of different schemes and programs that improve their lives is of interest. So if we do it right, then individuals come to the government or to service providers versus us having to chase them. But how we do it really becomes important. We see civil society organizations and community organizations being integral to creating demand and facilitating access. So how we involve and engage them becomes extremely important. Finally, we found technology to actually be able to mitigate some of the issues that we're talking about. Once you've been in the system, you don't need to keep showing up. We can automate certain processes. And in India, at least, we've ridden on the last 5 years of the various programs on whether it's been on financial inclusion or other services. Thank you.
Okay. Yes, thank you very much for having me. My name is Baby Rifona. I'm the only baby in this room. So, very interesting to be here because when we talk about the social protection for HIV, I'm the one people who get direct impact of what you're talking about for the last couple of weeks, of the whole week. So, honestly speaking, that what you're talking about, the social protection, or in Indonesia, we call that universal health coverage, or my community understanding about the national health insurance only. Can you imagine how abstract about this situation in the grassroots level? Yes, this is true. So the situation in Indonesia now, we still ineligible to get the funding from the Global Fund because of disease burden. So we got the commitment for that, but now we got warned also because the people living with HIV on the treatment is very low. Why? It's very low because there is some cases in Indonesia make this happening. For example, the bureaucracy for the registration to get the national health insurance, or we call it the BPJS, is too complicated for the key population, especially the key population coming from the MSM, LGBT, or transgender. Mostly they kick them out from the family, and they don't have the family card. They cannot register because they don't have the ID as well. How you can get the health insurance if you don't have anything with you? So you're talking about the social protection. That's what I mentioned before, that the ID card is complicated, and then also when you go to the facility, if you have the insurance, also is the process from the basic one, you have to refer to the district level, to the referral hospital, and then when you emergency only, you can get direct, etc. So I think that this has become a problem as well for me. If I have this kind of situation when I just can access for the basic one and go to the district level and go to the hospital, I'm dying on the street. So what should I pay my insurance? And also, because of the different level of this insurance as well, make a stigma in the health services. They just separate non-medical and medical services, etc. And also, we are in Indonesia, by the medicine is very high price. And now we're advocating our government to open up for the other pharmacy to get more, not monopoly, for this situation for the ARV. Then how to bring this all together? This is our question as well. The good things in Indonesia is the government commitment to provide the ARV for us for free, and also the TB medicine also for free, which is good, but not for the laboratory tests, like CD4, viral load. This is very expensive one. So, and also now we are almost more than 80% for people in Indonesia registered to be part of the national health insurance. And also we have 5% budget allocation from the government into the health. But my question again, the 5% goes to where? Goes to the salary, goes to procurement, or goes to where? So this is a specific Indonesia call for action from our community, from the key population. We want to be part of the universal health coverage, to monitoring, to be part of the planning, and also how to make the roadmap together with the World Bank, UNAIDS, UN Family, and also the WHO to have a better understanding. And this is the key message also. The fact is, like I said yesterday, that when we discuss how to make this language become my language, how to make this social protection, universal health coverage, sustainability development goals become community language, become grassroots language. That's what we need, because no one understands that. My community always say, you go there, I don't understand. So this is what the key message we have, and then we want to ensure we can provide everybody for the social protection, for the health insurance, and also how to strengthen the engagement of the key population, especially people living with HIV. And also one thing that we cannot work alone as a country with our community only. We have to work from the region to the global level. We have to make a big coalition. So this one is our call to action for all member states in the world. So we're not just working alone on this situation. This is the resource, what we have been done in Indonesia for the universal health coverage, VNR and SDGs, and also we make a workshop, and we have a finding from our workshop, and also this one, my campaign toward universal health coverage, and there is a lot of things I mentioned on this situation. So my understanding as people living with HIV who get benefit of what this program is, the social protection, we have financial instrument of social protection, cash, social transfer, government have it, the program of this, access to essential medicine and social services. We're talking about the universal health coverage, like what I mentioned before. And also financial problem also connect with this one, and social transformation for enabling environment is connect to the stigma and criminalize the key population. So you cannot just talking about the social protection, you have to talk overall. And we be part of that and put us as key population in top priority in the driving seat, so we can work together. Thank you.
Okay, good morning. I think it's still morning. Okay, thank you very much for the opportunity. My name is Harry Prabowo. I'm from Asia Pacific Network, People Living with HIV and AIDS in Bangkok, but originally I'm from Indonesia. For this occasion, I would like to talk about the community perspective on HIV-sensitive social protection. Before we start, I think I would like to bring back again a little bit on what is something from the health is human rights. From Article 25 of the United Nations, 1948, Declaration of Human Rights say that everyone has the right to standard of living, adequate of the health of well-being, including food, clothing, housing, medical care, and necessary social services. So, the way we see it on the social protection and universal health coverage, we see that it's reflecting a current global policy. Because we believe there is a global push for countries to adopt this policy change into sustainable development goals, and also in order to achieve UNAIDS target 1990 by 2030. But unfortunately, many countries are failed to adopt the global policy change be fully implemented at the country level. We also believe that this social protection is part of the reducing the medical gap, or our catastrophic expenditure, or out-of-pocket payments when we want to access the health service. For people living with HIV and key population affected by HIV, is also, we believe that this is a system that we want to increase health coverage and reduce new HIV infections by with the social protection, with financial support from the social protection. We as a community, we can access HIV prevention, treatment, care, and support. For me, as someone who's been living with HIV for many, many years, it helps me to understand my current condition from the treatment that I take for life. And also, I'm able to understand, to have a normal life like everybody else. And also, I'm able to be productive and still contribute to society and give something to everybody else here. So this is the main for us, the way we see it in the social protection and universal health coverage. We also see there is a country strategy to reduce or stop foreign funding dependency. We know we believe, I know it's hard when we're talking about country to fully stop dependency from the foreign funding. But let's say we have so much budget to buying gun or weaponry. Why don't we allocate that money for health? There's a pension funds out there, but still there. Why don't we allocate it for the well-being of our people? But the point is that I would like to try to say is, it's a matter of how serious country want to provide social protection and the health of its people, citizens. And we also believe that the social protection and USC model is vary from country to country. Some provided with goods, some provided with money, some with try to improve with the universal health care. So there's so variation country to country. As a challenge, we see stigma, discrimination is always priority. I'm not going to try to blame from the external, but there's stigma and discrimination is also coming from us, from our people, for people affected by the disease, any kind of disease. For people who disability, poor people, we have that, but that's why stigma and discrimination is part. That's still one I would like to highlight there. As mentioned by our panelists, there's a complex process of the social protection on USC. We also believe that social protection in USC, at this region particularly, is still a small coverage and still unsustainable. There also still lack of gender sensitivity. Somehow it creates less to establish empowerment for us, and it's not able to create safe space for us to be able to communicate, to talk about social protection freely. And the most challenge that we also heard that is there's hostility during the political climate, where political party using us as to gain benefit for their success of their party. So we care of access in the access in the health service or social protection. So, but we still believe there is some priority action that we have to consider. One is the sensitizing healthcare providers. We've been in HIV and AIDS, we've been talking so many times about sensitizing healthcare providers. But again, stigma, discrimination is still huge in all country, all hospital, all healthcare providers in these regions. But that's why we have to find a way to make a better approach, because probably the old way when we try to sensitize healthcare providers doesn't work. Same with the law enforcement. We also need to, there is also to improve access, coverage, and data analysis, so we can know people who really need the social protection, or people who need the UAC can really get, can be served by these systems. And we also wish that if the social protection and UAC can be used, involving us, involving the community, and we can have our ownership to these systems. So I would like to come up with something that we came up recently in the regional, that this is a social protection and a UAC that we want. It should be people-centered. It should be focused on people. It should be holistic, nuanced, responsive to multiple social identity across, within, and individual communities at one, some, or all point of their life. Second is an equitable and right affirming, which is right to health is for all. We should not look not just for financial barriers, it should put those who have last been first. It will not be achieved without the full inclusion of sexual reproduction health rights, since SRHR is the key core element and the right health to end of SDG. The last one, it should be meaningful, engaged community and civil society. Nothing for us without us. Community and civil society as equal partners. We dream of the systems that are equal partners of government, development partners, in designing, implementing, budgeting for, and reviewing the policy and the plan that affect us. Lastly, effective sustainable resource, right to health is not for sale. We also call international donors and global solidarity to ensure that bilateral and multilateral resources are allocated to marginalized population and community. So this is the last one. Thank you.
Thank you very much, David, Shama, Baby, and Harry. Before we go into the questions, I mean, this session could only allow us 4 panelists, but I'm sure there's a wealth of experience here. So if there's anyone, this is not about the questions yet, but if there's anyone who wants to make a contribution to what has been said so far, we'll be happy to take it now. Is there any contribution? Okay, if not, I can see some decisions being made, but okay. Do you have a mic?
Okay. Hi, this is Tariq. I'm the Deputy Chief Executive of Lighthouse. Lighthouse is a Bangladeshi national leading organization. In Lighthouse, we are working with the HIV prevention program supported by our Global Fund, and also we have the brothel-based female sex worker intervention supported by UNICEF and UNFPA and UNAIDS jointly. Under that program, just I'm sharing an experience about the social protection, how we bring the female sex workers under the social protection program. For that, actually, we have started, earlier there was no sex worker was brought under the social protection when we have started work in 2018. For that, actually, we started the work with the Department of Social Services, and we had a lot of advocacy program with them in the central level as well as at the district and sub-district level. And during the advocacy, we found there are the policy barriers, some policy barriers to include the sex workers under the protection services. The policy barriers like national identification number, the need for that. The policy barriers and for the most of the sex workers, they are not enrolled in the for the national identification number. And when we went to enroll them for the national NID, at that time the issue came for birth registration certificate. So that was so difficult. Because the sex workers in Bangladesh, most of them, the birth registration has started a couple of years ago in Bangladesh actually, so the sex workers doesn't have those. So then we had the advocacy meeting with the authorities who are involved with the NID, and several advocacy we did, and finally we were able to enroll them under the NID. And then we started with this, Department of Social Services for their program. And in between, we have started in February 2018, right, in Bangladesh, and last year, and until August, we have enrolled around 51 female sex workers under the social protection coverage actually, for the different type of coverage like old age bhata, maternity allowance, and also disability allowance, these kinds of things. And also 63 female sex workers we brought under VGF. So for this, we found our learning is to work one-to-one with the different ministries actually, because different ministries has different criteria or something like that. So that was the learning, and Mr. Oliullah, he is the Deputy Director of the Department of Social Services. He supported a lot for this, to bring the sex worker in the, under the social protections. And also we are planning to develop some special program for the sex workers where so Department of Social Services will help us. So this is the experience actually.
Thank you very much. Do we have any questions? I don't see any questions yet, but I think while we get the questions ready, I just want to pull together some thoughts that came through as we spoke. And I'll start with Harry. Harry said something that just struck me so much, so I wrote it down. He said, I want to have a normal life and contribute to society. And for me, that was a very powerful statement. I think the voice of key populations is summarized in this statement, that they want to have a voice and to be able to actively engage social protection systems. I think some of the barriers that we have heard today are barriers in design, you know, and when we come to questions, there'll be some specific questions I'll be asking, but we've heard about barriers in design, we've heard about the lack or thereof, the involvement of the community. To what extent does the community's voice contribute to the design of programs? Or even if programs have been designed, to what extent can community alter or contribute to changing some of these programs that already exist? Then there was another point that was made about the fact that in addition to the social protection program, the legal framework is key, because where some populations or subpopulations are criminalized, they can't even come out. They don't have a voice. They don't have a face. So all these have been mentioned. And I'll stop here because I think it's time. I want to hear from you. You've listened to us for a while, and please, if you have a question, let your hand go up. I don't see any questions yet on. I hear there's one on the screen. Yeah, there was one on the screen, but it's gone. So I think while it is gone, and it's probably going to. Oh, there's a hand there.
Hi, good morning. I'm Wai Chong from Singapore South Foundation. I'm working on aging mostly, dealing with another group of vulnerable people, you know, subject to abuse and discrimination at times. So I'm just wondering, I don't have experience with AIDS and HIV work. So I'm just wondering, in your work, have you, do you think that there is this issue of aging in people surviving beyond, say, in their 60s, 70s, and what are the challenges that you face? Is there situations with, does aging pose an added level of challenges to someone living with HIV?
Thank you very much. We'll take a few more questions, then we would go around to answer. Is there any other? Yes, please. At the back, yeah.
My name is Vimal Veera. I'm from Sri Lanka. My question is, you know, it is good, some of the countries, they have, you know, the social protection schemes for targeted people like HIV people. But my question is is there any program in these countries not only to provide social protection, but also to provide them, skills, get them, supporting them to undertake another jobs, or maybe, the formal sector or informal sector? What kind of, the programs that we can develop or policies, right, in order to get them into the development process rather than being, as sex workers?
Thank you very much. I think 3 is a nice number then. Yes, please.
Thank you. I'm Waliullah from Bangladesh Ministry of Social Welfare. In our country, for transgender program in our country, they also read in school institution and they get stipend from government. Right up to this moment, current fiscal year, 1,247 students are getting education stipend from government. Also, they get allowance from the government, around 2,600 transgender people. They get allowance from the government per month, 500 taka, Bangladeshi taka. And transgender also getting training program, like computer application course, motor driving, beautification, and other things. They get training from our different district of our country. And also 1,920 transgender also getting training and rehabilitation allowance from our government. Thank you. Thank you so much.
Thank you. So yours wasn't exactly a question per se, it was a contribution. But thank you.
Okay.
Yeah, thank you very much.
Also, we formulated action plan to cover HIV AIDS-related patient and others to ensure their social protection through income-generating activities in our country also.
Okay, thank you very much. So I think we can now go to the panel. We have 2 major questions here, one on aging and one on skills. So I think we'll just start. I'll start with David and then I'll come down.
Thank you. Thank you so much, Kofi. I think the issue of aging is really key. If you recall, one of the lines was going up because people are living longer with HIV. And sometimes many of us did not plan, many of us did not think we would be surviving, so maybe we didn't invest a lot in work or school or whatever. So in the end, we end up alive, but not without enough money. But at the same time, HIV on itself requires a lot of care. And if you add aging on top, it's more complicated. So there are more resources needed, but fewer pools to finance those needs. So yes, definitely, I think this is an important issue for us to make sure that older people are also connected to social protection services and that they are not impoverished to seek help. But also even for HIV, what we find is that most of the services don't target older people. We think older people do not have sex. So we don't target them. So when they show up for treatment, it's already too late and it's harder for them. So definitely I think aging is a very key issue for us, both for HIV and also for social protection.
Thank you. We'll come to Baby.
Yes, thank you. The first, I would like to inform you that in my country, Indonesia, now at the end of this year, we're going to raise the flag Indonesia free of prostitution. We don't have sex worker anymore in Indonesia. The government not not talking about the fast track to ending AIDS, but fast track to closing the brothel. That's one thing. And the second thing, 2020, war on drugs. No more drugs in Indonesia. So these two things affect our life as key population. I'm a drug user. I'm also living with HIV. And I'm also aging at the moment. So when we're talking about what the program for me, for us, yes, we have rehabilitation, we have cash transfer, and opportunity for the job, yes, we have, but also we have massive, all these strict anti-LGBT and anti-prostitution law. How we can get all these services? How we can come out? How we can get well-being in our health? And also, there is why you say why they not change from the sex worker to better life. There is no education, there is poverty, we have children, we only have my own body. I don't have anything to sell it. And my body is not belong to anyone. I don't need to pay tax if I sell sex. I sell services, right? Yes, so when we're talking about the aging and HIV, I'm the one, not many in Indonesia, less than 10 people, including me, still alive at the moment. Hello, 17 years now. So the first thing is adherence is very important, and the new regimen of ARV is very important, because now we are advocating the new regimen who less side effect for our body, and also the adherence, because we know when we are adherence to take the ARV, like me, for 17 years, I'm undetectable, equal, or means I'm untransmitted. So I have a children live HIV negative, and also I can be married again with the negative guy, if there is someone here. Yes, this is the reality. So if we want to talk about the good program for the sex worker, involve them, sit with them, ask them what the best way. If you want to talk about the HIV aging and also the social protection and universal health coverage, call them, sit with them, ask them what the best way. So don't design the program with moral approach, with the best from our perspective as a government, as the high people. No way. We are the beneficiary. We are the one who will access this program and services.
Thank you very much.
Yeah, so I think what I believe that we have to change our language. I think now, as just what maybe just come up from what Bobby said, that we usually top to bottom. We decide something, we create something, we try to engineering the designs, new systems that work for our citizens. But again, it's always fail. But now why don't we change that? Why don't we change that? We start from bottom up. Talk to them, and then we change the sound poverty. We change to asking them. This is about sustainability. We're talking about long term. It's about how you still contribute, how you can be productive, how you can be someone that have meaningful life. So that's what we have to think. I mean, I think we start to change. I think this is the way I also talk, not to the government, but also the community. We have to change our language now. We have to push. We're talking about, for example, vulnerable. We talk about the older transgender woman who's been living alone for many years, and then they're getting aging, and of course, but when we are to them, when they join together, when they can formalize retirement place for them. So I think, but again, we as another community, I mean, this is not only talking about HIV, but we also from other as a community as a whole, that we can help them. We can help. We start to think about aging. We start thinking about, broad that discussion. I think that's very important. Thank you.
All right, so I think, yes, I agree with Harry. We do need to change our language. And I think just covering all the points and just adding in a few more things, aging, not just for people living with HIV, but aging in the key population. So older sex workers, yes, are more at risk. Aging gay men, trans people, all of them. So I think and I think one thing that's not talked about enough is actually children living with HIV. We have far more children today who are adolescents and young adults and will become adults. And I don't think we have spent enough time in understanding what their requirements are at all, whether it's life skills, whether it's sexuality, whether it's family planning, many, many other things, and the kind of support systems that they require. So I think when I was presenting, and this is specifically to my colleague from Sri Lanka, we don't think of social protection as just additional schemes or programs created for key populations or people living with HIV. It is about them as citizens accessing everything that's available in the country. So yes, for some things we do need additional services or new schemes. So for example, we have something specifically for ART reimbursement or ART related transportation costs. But a majority of the time it is about access to the existing systems and schemes. So whether they are for employment, entrepreneurship, life skills, or financial inclusion, many, many times the key populations and people living with HIV will get excluded from simple things like opening a bank account. And I think we need to recognize that that stigma is very, very high. The discrimination exists. I know of enough stories where men and women and trans people, even with an ATM card, will sometimes be prevented from accessing their own money in an ATM. So yes, there are many, many schemes. There's a basket actually available in India, very vibrant alternate livelihoods, if you want to call it alternate, or diversified livelihood options, skilling, entrepreneurship that's being done. And I think the important thing is it's being done with community organizations. We could do a lot more, but I think definitely there is a lot that's happening. Yes, there was a question on the screen about stigma. Is there a way to prevent it? Is there a way to include it? Include it in as part of the SP social protection related activities. India has an act which prevents discrimination, stigmatization for access of services if you're living with HIV. I think that the legal framework becomes very, very important. If you can enforce prevention in that manner, then somebody who is being discriminated against at least has recourse. There are ombudsmen, there's a legal recourse if you are being denied access to certain services. And we have worked extensively across ministries for sensitization. We actually were able to bring 32 ministries together to understand why social protection in their own ministries and for key population is important. And there is interministerial working that allows for access to different services. So I think that kind of sensitization, and it's not once, and I think that's the challenge for us, ongoing basis. How do you keep the empathy and the focus on people? I think the biggest issue is that we forget when we're designing, we think of men and women and think of people we can relate to, and we need to expand that to sex workers or children living with HIV, and to think about people we don't necessarily understand but have different lived realities there. And I think that's the way we're actually going to be changing the future that we're all trying to create. Thank you.
Thank you very much. So we have 5 questions that have come in. I think Shama has quickly answered one of them, so there are probably about 4 left. And we'll take as many as we can before we wrap up. So the first one is we talk about the monetary and health service support. But do we need to add the emotional support and rehabilitation into the equation in making any schemes for social protection? I don't know who wants to take it. Maybe one person. Okay.
Yeah, absolutely. I think I've already said that. The scheme by itself, and if you, on my slide, we were talking about an impact study that we did. if along with the scheme you do not have support, whether that's emotional, whatever you call it, rehabilitation, motivation, just the feeling of being cared for by somebody else, that there is somebody that looks after you. If it's not your own family, then somebody else, right? Then actually that money and everything else really doesn't matter much. So yes, it's a very key part, but I think again, are we talking about government delivering everything? And I think that's where we need to start also thinking differently. This is about people also coming together, and I don't like to think of people as just being beneficiaries. Our communities are agents of change. They are empowered, they are able to do a lot of things. Are we able to allow them or enable them to do as much as they can and give them the space that they require? Because I do find that community institutions and civil society organizations do provide the emotional support or the mobilization or the caring that's required, if only we provided them that space. And if we engage them meaningfully, then along with the scheme, you also have the socio-emotional support that is required to actually lead the life you want.
Thank you very much. I think I'll take one more question here on stigma and discrimination, even though Shama spoke about it earlier. And I decided to take it because stigma and discrimination always comes up as one of the key barriers to accessing services. And I'll ask this directly to Baby and Harry. I want your perspective on this. Is there any program regarding fighting stigma and discrimination in relation to HIV? And can you give some examples of what success looks like, a success story from your experience?
Okay, so yeah, there are quite some modules. I mean, right now, so many countries try to implement the stigma index to oversee how stigma and discrimination level at one country. This is part of UNAIDS and some at the country level, at the regional, global and regional, and also us from the global network of people living with HIV. So in terms of, there is a lot of, but since we are, coming from PHA background, there are already some modules that come up from the UNDP. That this is a best success story that's happening in my own country, Indonesia. In the past, when we go to the healthcare facilities, people will always stigma of healthcare providers. They always see transgender or people with HIV, something, with the half eyes, something like that. But again, there's a modules. There's from UNDP called Time Has Come. It's basically we try to sensitize healthcare providers on MSM, TG, and MSM, TG, and PHIV. So this strategy has been scaled up across Indonesia, and now, but still, again, it's still the healthcare settings. And then neighboring country Malaysia tried to adopt it. And then another neighboring country, Timor-Leste, tried to adopt this strategy. It works. I mean, right now at this moment, under the Global Fund support, I also start working stigma and discrimination package, a component for the multi-country grant, which is applied in 8 countries: the Philippines, Mongolia, Timor-Leste, Sri Lanka, Bangladesh, Pakistan, 8 countries. So I think, but again, even the healthcare provider, the health minister said that, at least for now, you guys, key population affected by HIV can access the healthcare. That's what the first thing that, but again, we still have a huge homework from another key stakeholders, with stigma and discrimination for department this or department that, still not, we see, that's why right now the homophobia is still on the rise because the political tension that's happening in Indonesia.
Thank you. So, Baby.
Yes, I'm interested to answer what are the strategies used to detect the HIV? I can answer no way you want to detect if I'm not tell you I'm HIV positive, right? So if you want to know, your status, you just go to healthcare. You're asking for testing. I want to know my HIV status. That's all. But what the best strategy, say zero stigma and discrimination to people living with HIV. That is the best strategy, not to detect them. So when you can address it, zero stigma and zero discrimination for people living with HIV, there is no more people kicked out from the school. No more students kicked out from the school because of HIV status. It's happening in Indonesia. No more people fired from the job because of HIV status. No more people banned to the country as a migrant because of HIV status, like me. I'm also deported from the other country when they find out I'm HIV positive. So many things happen in my life in 17 years because of HIV. That's why I'm still here to talk with you, to say that no more zero stigma and discrimination for me, for people like me, for people living with HIV. That is the best strategy.
Thank you very much. David, I want you to speak on what are the strategies used to detect HIV.
Thank you, Kofi. I think my colleague really mentioned the key things. If we can address the stigma and discrimination, it makes it easier for people to come to the services, but also the populations that we are dealing with, often they face a lot of things. So addressing, for example, their transport needs. If you recall one of my slides, we said we have to provide combination services, creating incentives. Often, for example, people who inject drugs, we say that they will not come. We say that they don't come to the services, but we know through research that if you provide incentives, they will come to the research for testing. If you can address the issue of their child care, for example, they will come to HIV test. If you can make sure that they are not going to be deported, they will come to these services. So I think the key thing is making the HIV tests available is not enough. We have to address these surrounding things, and we believe that social protection has a key role to encourage access and use of HIV services.
Thank you very much. The last question, I think we've done a good job. We will be able to answer all, and I'll give that one to Shama. Yeah, in a scenario of inadequate benefit package, what are the pull factors you would consider?
All right, thank you. So just answering that question quickly, if it's already been identified as inadequate, I think we start there, right? So there is something that works and there's something that doesn't work. So whatever is working, take it. What's not working, let's see for how many it's not working. And then can we advocate, can we engage with the government to actually try and modify that? And we've seen that with data, and that's why I said it's useful to have a lot of data and use information to actually make the case, because we have had success with going to the government saying, this is the number of people who are either getting left out or not getting access to something simply because you've added this line in there. And will you take it off? And when the question was how many is it preventing, and we had data, right? We had information to say this is why it's problematic, this is what it's doing. And we were able to get them to change those things. We've actually seen very good participation from, even something like the Election Commission, which is not necessarily thought of as anything to do with social protection, but for each one of our individuals, whether they're PLHIV or from the key population, to be a citizen, they need to be able to vote. And as an identity and as a power that we give every citizen, we've been able to get them to come in and say, if you have 100,000 people who are not on the voter list, we'll make sure that they get there. So I think the big piece is to actually get into the specific, what is inadequate, why is it inadequate, who's saying it's inadequate, what numbers is it affecting, and then can we work with the ministry or the concerned department to actually make the change. And I really believe that it is It's not about them and us, it's us together, and we can make the change there. I just wanted to add something to what David was saying. One of the other things that WHO came out with in terms of screening guidelines was to say lay provider screening for HIV. This was guidelines in 2015. I don't know about the other countries, but India adopted it in 2017. So we actually have outreach workers who are being trained now to provide screening services for key population on the ground, wherever they are. So they don't need to travel, they don't need to come out from wherever they are to some one big city to get it tested. The services go to them, and that's another way to actually look at screening for HIV.
Thank you very much. I think now it's time to hand over to Michael, who will just sum up what were the key messages that came out from this session. So over to you.
Sure. Thank you very much, Kofi, for moderating the session. I want to thank the panel as well, thank the audience for their attendance, and also their kind of rich and engaging questions that they've posed to the panel. I think it's also quite clear to see from the passion and the knowledge base that's on this panel here, it's safe to say that we've indeed saved the best for last. I think summarizing is going to be difficult, but I'll take a stab. We obviously have learned a lot from these presentations, and I think we're kind of seeing two stories unfold. And I'll start with David's presentation. I think while we have made tremendous strides globally since 2010, there are certain regions that are obviously suffering, that are at risk of falling behind. David showed a slide in the Asia-Pacific region where incidence in the Philippines since 2010 has increased by over 200%, which is shocking. So, of course, globally in the last decade, we've made a lot of progress, but there's still a lot to do. Kofi opened our session by referring to the 2030 Sustainable Development Agenda, and obviously you've heard from this panel that I think if you want to stop leaving people behind, you have to reach the furthest behind first. And in order to do that, I think going forward, governments and implementers, NGOs, the UN, you need to focus on integration and sustainability when talking about social protection. I think the days of UN, NGO, implementing partners going in and running programs for 1 or 2 years, funding drops off, you pull out, you've left a programmatic vacuum. And what are those beneficiaries, what are those communities left to do? They're gonna suffer. And we've heard all week that really, if programming is not sustainable, then you're not really talking about social protection. I think we also need to highlight going forward kind of the significant return on investment that investments in social protection programming yield. Valerie Schmidt earlier this week mentioned that for every dollar spent, you receive a return on 150, so that's 50%. And Sham and I were discussing before the panel, she was talking about a social ROI index. And spending on social protection yields 29 times returns there. So obviously there's significant returns on these investments, and I think we need to not get too focused on creating supply where there is no demand from our communities. And above all, we need to connect with our communities and listen to our beneficiaries. And one of the ways you can do that is through outreach, and that's key throughout kind of the service delivery value chain. And if you're not doing that effectively, that can lead to information gaps. And of course, that reiterates the strong need for linkages with communities on the ground and grassroots movements. So our focus needs to remain on key populations to end the epidemic and leave no one behind by 2030. But we also need to make sure that we don't lose sight of our beneficiaries and move ahead with UHC implementation when our foundations are not secure and the people we're trying to help and help serve don't understand UHC, they don't understand the SDGs, and they don't understand the language and the messaging that we use. So I think in summary, if we're trying to cover everyone, wherever they are, we need to have communities in mind when we're implementing our policies and programs from the first step. Thank you.
Thank you very much. So that brings this session to an end. And I think before the panelists leave, please give them a hand. Thank you very much. We don't want to stand between you and lunch, so we would stop here. Thank you.
Thank you, Kofi, and the wonderful panels we have here. And the summary is excellent, by the way. So for the filling out of the evaluation form, please do so on the platform. I'm told that it's on the same platform that you've been using to ask questions. And then after lunch, if you want to come back to different working groups. It will be divided into different sections here, and you can join the discussion from 2 to 4, and that's for the next step on what to do next after this workshop. Thank you. There will also be a closing ceremony here. But lunch is now, right? It's upstairs? No? Oh, lunch later. So closing ceremony first?
Yes, and then lunch. Please stay in the room. We will try to gather participants from different breakout sessions. And this is where we're going to organize our closing ceremony. Okay? So just stay and get yourself comfortable here. Maybe we will start in 3 to 4 minutes. 4 days event. Before I start with the closing ceremony, can we all have ourselves a big round of applause for a big participation for the 4 days? We hope it has been a great learning experience and networking opportunities for you in the past 4 days. Before we start with our program, I would like to, on behalf of the organizing committee, express our deepest appreciation for your strong participation and collaboration in the past 4 days. We really appreciate what you have done together in this forum. I would like to share some information before I would like to invite our Chief Thematic Officer to deliver closing remarks. In the past 4 days, parallel to the Asia Pacific Social Protection Week, the Global Action on Disability, or GLAD Network, ran a parallel training session at the ADB on strengthening advocacy for social protection reforms that promote inclusion of persons with disabilities. This is the first of such session that is organized in collaboration with the Asian Development Bank. And in this context, we would like to give the opportunity to our colleague to share some of the experience and also takeaways from the training session. I would like to invite now Ms. Caroline Dagani. She's representing the Asia Pacific Disabled People Organization community. So she will deliver her remarks in sign language in Filipinos, and it will be voice interpreted. Thank you.
On behalf of all my fellow disability advocates from the Asia Pacific region, we would like to thank ADB, ILO, UNICEF, and IDA for creating this opportunity to engage during the Social Protection Week, where we are not only spectators, but have an active part of. During this week, we realize we do not understand all of the debates about social protection. In the same manner that social protection professionals do not fully understand all the discussions pertaining to the rights and challenges of persons with disabilities. For us, social protection is critical for inclusion, especially to attain equity. The extra costs of disability need to be considered. Also, we heard that the world is changing in relation to work, and us in the disability movement have a solution. As a response to this, we and the elderly need a lot of personal assistants and sign language interpreters. And social protection plays a vital role in making this a reality. We look forward to more engagements with all of you and in continuing the dialogue at the country level, because we believe that there is nothing about us without us. Thank you.
Thank you, Caroline Dagani. We're really encouraged to hear from her today, the message that even though this event is not entirely inclusive to disability issues, but we manage to give space and also opportunity for our colleagues from the disability group and organizations. We would like to hear more from you, so we invite you to also give feedback through your app on the evaluation form on how we organized the event in the past 4 days. before I hand over the floor to Ms. Chiara Bronchi, I would like to invite you also for this afternoon to participate in different sessions that will really take this event forward. We would like to discuss concrete actions that we can take forward from this as a follow-up to this event. So we will have a breakout session starting at 2 until 4 today on 6 different issues related to social protection. So the information is available on the app, but I will just read through, and then maybe during lunch you can think through on which area you will be interested in to participate. So the 6th session will be, one is on facilitating data collection on monitoring social protection in country, regional, and global level, that one. And the other one is on fast-tracking HIV-sensitive social protection in Asia Pacific. The 3rd session is financing social protection for achieving sustainable development goals. You can hear the experience from 6 countries: Azerbaijan, Cambodia, Indonesia, Myanmar, Timor-Leste, and Uzbekistan. So for those of you who are interested in peer-to-peer learning from other countries, this would be a great session for you to join. Another one is a roundtable on developing evidence base on aging and long-term care. And the last 2 is social protection in Inter-Agency Cooperation Board, or SPIAC-B Digital Social Protection Working Group meeting. And the last one is Transform program. So do sign up. We really welcome your inputs and also contributions to come up with a concrete action plan from this event. Now, I would like to invite Ms. Chiara Bronchi, our Chief Thematic Officer, to officially close our 4 days event.
Good afternoon, everyone. I'm delighted to be here today, and honored also to be able to bring some concluding remarks to such a wonderful group, and also to thank a number of you that have contributed to this great event. The past 4 days have provided a fantastic overview of the trends, challenges, and solutions for improving social protection in Asia and the Pacific. And with the support of our 15 partners, they're all listed behind me, the forum has delivered 26 sessions and delved into several dimensions of social protection. There have been prominent speakers, incredibly rich and insightful discussions, and plenty of opportunities for learning and networking, and which I hope you're taking advantage of. And of course, I also want to encourage you today to attend the action plan sessions this afternoon. The main objective for this forum was to stimulate the thinking and innovation based on scientific evidence, but also from first-hand experience of colleagues, friends, partners from around the region and beyond. And allow me now to highlight a few moments of these 4 very intensive and fruitful days. I think one of the central messages of the event was the importance of enhancing social protection coverage in Asia and the Pacific. This requires increased efforts to create fiscal space and boost social protection financing. In this context, we need to shift mindsets from thinking about social protection simply as expenditure, as to see it as a set of critical investments for securing the future and a major tool for achieving sustainable development goals. And addressing poverty and inequality, I would say actually to eradicate poverty once and for all from the region. We also learned that we need to work across silos to achieve this, and in partnership with Ministry of Finances, among others. The importance of addressing the gender dimension of vulnerability across this life cycle and designing schemes with a gender lens was highlighted by our distinguished speaker, Professor Naila Kabil, on the first day. This is a challenge we must all rise to if we truly want to make an impact for all. We have social protection instruments such as conditional cash transfers, community-based financing, child grants, social pensions, and graduation programs, which are effective in addressing different aspects of poverty and vulnerability. However, they need to be carefully designed, implemented, and monitored. In other words, we need to adopt agile approaches. Areas which need further strengthening and development include approaches for persons with disabilities and those with HIV/AIDS, extension of social insurance to the workers in the informal economy, and development of adaptive social protection. There is also an urgent need to plan and adapt to demographic changes in many countries in the region through the development of long-term care and strengthening social security. Some of our discussions have also addressed the importance of anticipating the future of jobs in light of the fourth industrial revolution and how social protection systems should also evolve in this direction. Participants emphasized the need for embracing the effective use of technology in the design, delivery, and monitoring of social protection to ensure accurate targeting and improved efficiency and governance. They also stressed the importance of having updated and comprehensive data to build evidence-based social protection programs and measure their impacts. Another takeaway from the session is the need to promote integrated approaches to find solutions for social protection challenges that do require, I was attending the latest session actually in food security, to look at ecosystems, to embrace and to support the social protection reforms. This requires fostering inclusiveness and coordination among government agencies, development partners, private sector, civil society. It's an ecosystem that has to work together to make it happen. Lastly, the importance of promoting regional cooperation and expanding the knowledge base and capacity of the countries to design and implement social protection programs and learn from each other. I would like to thank you all. This is now my last few points. For a wonderful participation, and I would say active participation, and to thank all the collaborating partners, agencies which held the exhibitions, and the speakers who shared their knowledge and experience. And my thanks also go to our colleagues across the ADB, and many of them have contributed to this forum, and they put their time and passion and commitment. And finally, I would like to recognize the Social Development Thematic Group team here, who is, I wish they could stand up because they really deserve a big applause. They've been the beating heart of this forum. And what they have assured, everything moved around really smoothly, including for me, I have to say. So Shri, Yuki, Ayun, Amy, Lydia, Lois, Becky, Jen, Wendy, Mitch, really, again, big thank you. As you heard and as you know, the agenda going forward is still huge. We heard that there are about 300 million still below the poverty line in our region. There are opportunities to make changes, but we really need to work all together constantly and persistently on the same objective. And we do definitely have an opportunity to make an indent in this, in their people's life in this region. So I definitely hope, and on behalf of ADB, we hope to see you all again on 2021 Asia Pacific Social Protection Week. But in the meantime, let's continue this dialogue and the good work and action plans, and let's make them real on the ground. So thank you again all for the participation and for making this a fantastic 4-day event. Thank you so much.
Thank you, Chiara. Now it's time for lunch and time to say until we meet again, and have a safe journey home. Do stay in touch and build on the connection that you make in this forum, and hope to see you again in 2021. Good afternoon, everyone, and enjoy your lunch.